Are you muting yourself until you go, or no? We can talk.
No, we can't. It doesn't matter. Everyone can hear. Okay, everyone, I think we're going to get started just because it's 3:02, or sorry, it's 12:02 your time. We're actually on the East Coast, so sorry about that. So anyway, welcome everyone. So glad to have you here at the first of our 6 webinars for small to medium-sized practices on supporting small but mighty practices in screening for and addressing ACEs in California. Next slide. Okay, so I'm going to tell you a little bit about how this is going to work, and then we'll really just dig in. So this is the first of a series of 6 webinars that are targeting screening for ACEs and implementing trauma-informed care for small to medium-sized practices. We define small to medium-sized practices as around somewhere between 6 and 7 providers or fewer. I hope you'll join us for as many of these that you find relevant. And also I want to note that the webinars are really about 1 hour long. And the idea is that the facilitators will stay on for an additional hour or as needed to answer individual practice focused questions or offer advice and support as needed. Next slide, please. So I want to introduce myself, obviously. My name is Yael Lipton. I am a trainer with Primary Care Development Corporation. We are a national nonprofit based out of New York City, but with offices in California and DC. And our mission is really improving primary care for underserved populations and communities. So we're in the New York metro area. And I'm trained as a health educator and really spent the first half of my career providing direct services and programming in underserved communities throughout New York City, mostly through federally qualified health centers and also some reproductive health centers like Planned Parenthoods. I've also been training healthcare and social service staff in a ton of different topics, things like health literacy, person-centered care, cultural humility, team-based care, reproductive health and others, and including trauma. And for the past 5 years, I've worked part-time for PCDC, traveling around the country, training various healthcare staff on programs, person-centered programs like care management and trauma-informed care. So I'm happy to be here with you, and I'm also going to let Angela Fernandez, our co-presenter, introduce herself briefly.
Thank you, Yael. And hello, everyone. It's nice to be here. My name is Angela Fernandez. I am currently the Assistant Director for Mount Sinai Hospital System's Sexual Assault and Violence Intervention Program. I similarly to Yael, I started my career as a health educator and spent many years really focused on sexuality education and reproductive health, and then moved more into the work of gender-based violence. I've been with the SAVI program for total in different capacities for about 13 plus years, but also had the pleasure and opportunity to work more closely with Yael at PCDC a few years ago, also focusing on person-centered care. So I'm really excited about bringing this to you today and really talking more about trauma-informed care and hopefully provide some examples of how we're trying to implement trauma-informed care into our own hospital system here. Thank you.
Thank you. Next slide, please. So we have a lot to get through today. I should say that some of this will be review for some of you, but it also seems to always make sense to level set so that we're all on the same page with how we're understanding the topic and the language that we're using around it. So this will be recorded and it will be available on our website shortly after. I know most of us are very familiar with Zoom at this point, but use the chat box to ask questions or make comments. We'll be monitoring throughout. We'll stop as necessary to answer questions, or we'll respond in the chat box if that makes more sense. Both of us are trainers who up until a few months ago, have facilitated in-person training primarily, so we're not as comfortable with this format, and we really welcome participation in any way that we can get it. After the webinar, you will be directed to an evaluation. We really hope that you'll fill it out as we take it really seriously, and it informs what we're going to do here moving forward. And I'll go over the topics that we're going to cover for the next 5 webinars at the end again, so you can take another look. Okay, let's get started. So next slide, please. Okay, we're going to start with a case study, and this is going to require a little bit of participation. So Isabel is one of your patients who's 6 months pregnant, has diabetes, and has been recently diagnosed with hypertension. She's not been keeping up with her prenatal visits, no matter how many times the importance of this care is discussed and how many appointment reminders have been given. She keeps no showing. Okay, so if you could just chat in, you know, kind of initial reactions to her. How do you feel about her? You know, how do you think others would feel about her? What assumptions would be made about her in a healthcare capacity? Don't be shy. Frustrated, yep. Concerned about her safety, absolutely. She's obviously struggling. Okay, we obviously have very trauma-informed people already on here. Overwhelmed. Wondering what's happening. Anything else? Wondering how best to support her. She may have had a bad experience with providers in the past. Okay, great. So many of these, right, are actually very trauma-informed, but for those in healthcare who are not, you know, I would say sort of in the beginning of my career, she may have had I would probably be really frustrated, kind of annoyed with her, and just feeling like, you know, what else could I do? Like, there's really not much else I could do at this point. I've done everything I can, and it's in her hands. So we're not gonna talk about this anymore right now. We're gonna come back to Isabel at the, you know, later. And so just keep her in mind though, as we're going through everything. So I'm actually gonna hand it over now to Angie to take us through, oh, someone says, unable to see the participants or any of the chat messages you were reading just now. Okay, I don't know, Kim, is that something we can? Someone's saying they can't see the comments.
Oh, right. It looks like they're just going to panelists. So I can adjust that for the next sessions.
Okay. Sorry about that, guys. Okay.
So as Yael said earlier, you know, this first session is really to level set. And so some of this may be a review for you, but we thought that it would be important to start with really going back to the basics of what are we actually talking about with trauma. So, you know, what is trauma? You've probably seen a definition similar to this, if not exactly this. But what we're really talking about is a series of events, one single event or set of circumstances that can be experienced by an individual, a community, or a group of people. And what makes trauma very unique and different from maybe a generally stressful situation is that there is a threat, whether it's real or perceived, but true and real threat to one's safety and well-being. It usually ignites a fear reaction, feeling terror in some way, and really most of the time traumatic events, people will recall them as something like, I thought I was going to die in that situation. Trauma, as we know, has lasting adverse effects on the individual's functioning and really has an impact on us emotionally, socially, psychologically, physically, medically, and spiritually. And the main piece to any traumatic event also is the sense of losing control. So people who have experienced traumatic events really were in situations where they've had, with a lack of autonomy, and absolute control taken from them. Next slide. Thank you. So when we think about trauma, we might be thinking about it in a few different ways, right? So we have examples of acute trauma. So this is one single isolated stressful dangerous event. And when we're thinking about an acute traumatic event, we're thinking things like maybe a serious car accident, a natural disaster. When we think about trauma as more chronic, that's something that you may have heard before as more of a toxic stress situation. These are traumatic events, but they are things that people are in for a prolonged period of time. Things like that, we're talking more around child abuse, child neglect, domestic violence situations, bullying situations, homelessness. So again, that feeling and that situation where a person's safety and well-being is being threatened, but in a very chronic, long-term type of state. And then we have something called complex trauma, which is just now being understood. Complex trauma is really the result from exposure to multiple types of traumatic events and situations. And I will say that from my experience in doing direct trauma work, what we're learning is that very few people who have a trauma history have had one single isolated traumatic event. But what we do know is that people who have experienced one form of trauma are already more likely to experience other forms of trauma. And so the reality is that most of us, and definitely in healthcare, will be encountering people who really do fit the definition of more complex trauma. Next slide. Examples of traumatic events, and please, this is not an exhaustive list at all, but some of these things that are probably already known to most of you here are things like childhood neglect and abuse, and we'll be focusing a lot on that because of the ACE study. Sudden unexplained separation from a loved one, war or terrorism, so people who've experienced this as civilians and also members of the military, natural or man-made disasters, pandemics. So our current situation right now, we're all really collectively experiencing a traumatic event. Things like homelessness or home displacement, incarceration, various forms of gender-based violence, so sexual violence, domestic violence, sex trafficking, and then things like serious medical illness or being diagnosed with a new medical illness and more long-term chronic conditions. All of these are examples of what might be a traumatic event for someone. Next slide. We also have something called historical trauma, and historical trauma, which can also be intergenerational trauma, is something that's experienced by a collective group of people, and then is that traumatic response is basically passed down from one generation to the next. It's usually experienced by a specific cultural, racial, or ethnic group. And when we think about historical trauma, normally different forms of oppression come to mind. So for example, slavery, Holocaust, forced migration, the violent colonization of Native Americans. And really what we're seeing even right now in our contemporary society, so for example, Black Lives Matter is really a response to historical trauma, right? And so this is really, we just wanted to make a special point of this, especially considering this really the climate that we're living in together right now. Next slide. So a great expert in trauma in the field is someone named Dr. Bessel van der Kolk. And there's a great quote that I want to share with you that he says, after trauma, basically the world is experienced with a different nervous system, right? And so trauma and what we call the neurobiology of trauma, which again is really a newer field of research, is really understanding what that brain-body connection is. And what we see sometimes on the surface, which is more kind of behavioral or coping types of mechanisms, is a response to trauma, is much more deeply rooted in to the point of cellular levels, right? So trauma really can change our brains, and it can change the mechanisms and systems that really function in our body. and affect our health long-term in a variety of different ways. So I am going to say, as a disclosure, I am not a brain expert. And so this is going to be a very, very simplistic, quick overview of obviously a very sophisticated, complex system that really is developed over thousands of years, right? Which is our brain. So next slide. So when trauma meets the brain, what we understand and what we know now is that there are certain parts of our brain that are mainly impacted. So we have the prefrontal cortex, which is that front of our brain, and that's the newest really part of our brain, right? It's the brain part of our brain that is really known as kind of the thinking, rational part. So this is the part of the brain that can plan ahead, that can reason things. It can finish that sentence, that concept of if this, then that, right? It also helps us have more regulation over our emotional responses. And it really is the main part of our brain that helps us with impulse control, right? So it's the part of our brain that we usually are talking to when we have an emotional response. And thankfully, that prefrontal cortex is the part of our brain that says, no, Angie, calm down. Don't go and say this right now. It'll get better later. If we didn't have that, we would be much more uncensored, right? The other part of our brain that's really impacted in traumatic events is the amygdala. And so the amygdala is really known as the primitive part of our brain. It's the reptilian part of our brain. It's the raw emotion part. It's part of our limbic system. And that's the part of our brain that's just constantly sussing out what's safe and what's dangerous, right? It's the part of our brain that really helps us survive. And that's what our brain is designed to do. It's really designed to ensure survival. And it works really amazingly. And during development, from the time that we're in the womb to all the way into our young adulthood, our brain is continuing to develop, and it really develops from a bottom up way, which means that the amygdala, when we're first born, is the part of our brain that's most active, and then as we develop through the years, our prefrontal cortex is what becomes more mature, right? So what happens is that our brain in a traumatic event really starts to fire off messages, and the part of our brain that is more primitive, the amygdala, becomes the main active part of our brain, and the front part of our brain, that prefrontal cortex, is then kind of paralyzed or suspended. And so all of those things where, that rational thinking and problem solving and all of that are no longer available to a person. And what kicks in is that fight or flight response, very, very raw response, because the brain is saying we're in trouble. It senses danger, and that's all that it takes for the brain to start to think about how are we going to survive this threatening situation. Next slide. So again, very, very simplistic overview. This is basically what it shows. This is a mapping of what happens. So we are encountered by this very stressful, extreme, fearful event. And it kicks in a variety of different types of responses, basically determined on what the situation is. So fight or flight, freeze if fight or flight is not available, and then collapse if fight, flight, and freeze are not available, right? And so they all serve different purposes. And they happen, and then normally after that threatening event, what normally should happen is that the cortisol levels go back to normal. So all of those different chemicals that are being released in that stressful event, and we've all had that feeling, right? Start to calm down, the body starts to regulate, and you're no longer in that high, intense, very energetic, panic feeling. But in situations of trauma, and especially chronic trauma, and also depending at what point in development the traumatic event happens, some people end up staying in a chronic state of fight or flight. So cortisol levels continue to be high, even when that dangerous situation doesn't exist anymore. And the other piece of that is if someone is in a state of freeze or collapse, which is another coping mechanism, and instead of that cortisol, like high rush that's being released, our body releases other things so that we don't feel pain. So things like corticosteroids and opiates. And sometimes that prolonged response can remain. And you might find that someone, rather than being jittery and jumpy and hypervigilant, you have someone who has more of a flat affect, a reduced energy, a numbness, an apathetic affect. Right? So our brain basically is very complex, and it really will respond in situations to help us survive. It also will impact, when these responses happen, the way a person maybe encodes memory, and it also can change the wiring of the brain. So basically the neurons that fire together will eventually wire together. So in the future, every time that fight, or every time someone may be triggered, every time something reminds a person of a fearful event, that response will kick in exactly the same way. And so now you have somebody who is matching up something maybe familiar but isn't threatening anymore to this automatic fight or flee response again. Next slide, please. So the effects of trauma on the whole person are, this is not an exhaustive list, but these are some things that are more directly relevant to our topic and why we're here together. On the left side, we see more of the internalized responses. So a lot of shame, self-blame, guilt, anger, sadness, fear for individuals that have experienced a traumatic event. And this becomes something that can lead to isolation and alienation, depending on the type of traumatic event the person experienced. And then more longer term, so we see some of these acute responses, and then longer term, what we see is that direct correlation to things like depression, anxiety, post-traumatic stress disorder, eating disorders and obesity, hypertension and heart disease, substance use and abuse, right? A lot of chronic health conditions that we see that are really plaguing our culture that are directly correlated to trauma. I've also asterisked the hyperarousal piece. That's what I was really talking about earlier, that hypervigilance. So people are really on the defensive all the time, right? Kind of that, I know that expression of like, don't let your guard down. And this is really kind of a literal example of what that means. So a person who's experienced trauma, who now has hyperarousal, that person is always blocked off, right? Always on guard, always in preparation for that fight, flight, or freeze response. What we see how that plays out is later on, that's also something that makes it very difficult for people to connect with one another or have any sort of intimacy with other people. So again, that can lead to extreme isolation. And then not surprisingly, things like depression, anxiety, and higher suicide rates. Next slide. So these are just some examples of literature that really supports what we're saying to you right now, and what we're learning more and more based upon that landmark research study that was done about adverse childhood experiences that we're going to talk about in a moment. But you know, if you have time, it would be great for you to glance at these things and really how we're making that direct connection now between early traumatic events and chronic trauma to organic disease development later. Next slide. So the psychosocial impact of trauma is really this breaking of trust. So trust of other people, but also trusting in oneself. It breaks connection, and again, connection to others, but it breaks connections to oneself, right? So when we think of a traumatic event, things like, for example, I don't know how many of you have, you know, relied on this expression, but that idea of like, trust your gut, go with your gut, right? Well, what trauma does is it basically makes that connection to your gut instinct, right, which is a real thing, not clear. So either someone may misread the messages and not be in touch with it, or might not respond, or may try to ignore some danger signs. So what it does is it really starts to have a person doubt whether or not that they are able to able to notice or pick up on things that would keep them safe. So it really does break that trust and connection with oneself. It also can lead to a disconnectedness and an alienation from the rest of the population, right? So that break in the sense of belonging. And we know that that's such an important human element, right? We are humans as a species. We need to connect with other people, right? We're a social species. So when we look at these things, it has very, very serious health consequences when we think about people not really being connected to themselves and then losing that connectedness to others. And so in a sense, basically what that means is that smoke detector that goes off when we're trying to sense danger and safety, it's not working anymore. And we hear this from a lot of trauma survivors. It also is unfortunately a big indicator of why trauma survivors are at higher risk of experiencing more trauma. Next slide. So the prevalence of trauma is really great. We know now that it's more likely that people we're interacting with in our personal lives and in our professional lives have experienced a traumatic event rather than haven't, right? So 70% of adults in the US have experienced some type of traumatic event at least once in their lives. And over 90% of patients who are seen in public behavioral health clinics have experienced trauma. So what this says is that, it makes sense that in healthcare, we are now incorporating trauma-informed principles because it's very likely that you are going to be interacting with patients who have a trauma history. Next slide. So what determines the impact of trauma? We know that there are people who can be in the same family. We know that people, right, can live under the same home and will have very different responses to a traumatic event they both experience. So there are very, very complicated biopsychosocial and cultural factors that will influence an individual's immediate response and long-term reactions to trauma, right? So some of it is just how we're all wired at the time that we're born, right? And then the other aspects are really what's going on culturally, environmentally, and how those things really interact with one another. It also has a lot to do with at the point in time when we experience trauma and what type of traumatic event it was. So what a child experiences and what's going to have a long-term impact on them may look different than an adult traumatic event and how it affects them. We know that some people have more acute and shorter term responses to a traumatic event versus people who have long-term chronic issues and impact from traumatic events. Next slide. So the reason why we know so much about this now is because of this amazing study, which is crazy that this happened over 20 years ago, and we're just starting to take this and incorporate it in a serious way, right, into our healthcare systems. But the Adverse Childhood Experience Study, which I'm sure most of you are very familiar with at this point, was a very large study done in the 90s, the late 90s, it was in collaboration with the CDC and Kaiser Permanente in California. And the lead researchers in this study were Dr. Vincent Felitti and Robert Onda. And how this came about is that Dr. Felitti actually had been running an obesity program also in California about a decade earlier. And what he found was very surprising. He was working with people who had significant weight loss they needed significant weight loss. There was obesity where people were needed to lose 200, 300, 400 pounds. And what he found was about halfway through the study, he was losing a ton of those participants, and he didn't understand why, because many of them had actually lost the weight that they were trying to lose. So from a surface level, he was wondering, like, you know, this seems like a very successful program, yet we're losing half of our participants, and what does that mean? So basically, after meeting with a lot of the people who dropped out and having conversations and actually doing it in a way where he kind of stumbled upon a person to disclose, what he found was a significant portion of those participants had a history of child sexual abuse, and that the weight gain wasn't necessarily the problem, right? From a medical standpoint, the obesity was the problem. But for people who had experienced this very serious childhood trauma, the weight gain had been part of their solution, helpful, something that was helping them cope with this very, very terrible event that happened to them. And before that, right, medical care, healthcare really will look at just the problem and look for identifying a problem, rather than really asking that other question, which is, instead of, you know, what's wrong with you, what has happened to you? And that can explain a lot for around people's behaviors, coping mechanisms, and maybe their resistance to some medical guidance that from an outside standpoint, we would think, why wouldn't this person want to get better, right? So fast forward, Dr. Felitti found some really interesting and very important information and understanding about his patients. And finally, after many years of trying to get attention about this, the ACE study was conducted. They had a sample size of over 17,000 people, and the participants came from a really good, basically an HMO. And so the sample size was comprised mostly of white, middle, upper class, college educated people who had good jobs and good health insurance, right? And they identified 10 different categories to screen these participants in. 5 were personal, so it was looking at different experiences of physical abuse, verbal, sexual abuse, physical neglect, and emotional neglect. So any one of those things that happened to a person in their childhood up to the age of 18. And then the other 5 were more around the family and kind of assessing the dysfunctionality of the family and home environment. So this was looking at parent who was an alcoholic, a mother who may have been a victim of domestic violence, a family member being incarcerated, a family member being diagnosed with a mental illness, or the disappearance or abandonment by a parent.
Just a quick time.
And, oh, thank you. Sorry. And what they found, the study's significance, was that trauma was very common. 87% of the participants had reported 2 or more ACEs. So every experience, every different type of adverse childhood experience would get 1 point. And so people who had 2 or more ACEs, that equivalent of 87%, and that ACEs is cumulative and long-term. So the more adverse childhood experiences someone had, the longer they endured it, the higher their score. Next slide. Meant that the higher risk, and they were more likely to develop these chronic conditions in adult life. So for example, someone who had a score of 4 or more was 1.6 times more likely to then be suffering from severe obesity in adult life. All the way up to, if you look at the bottom, attempted suicide. Someone who scored 4 or higher was 12 times more likely to attempt suicide. Next slide. When we look at the risks and the effect on all of these different chronic conditions that we've been trying to address, right, individually, and smoking cessation programs and healthy lifestyle programs for obesity, and maybe smoking could impact a person's lifespan by 10 years, due by 10 years, or diabetes 7 to 8 years. What this study has really pointed out, and other studies that have come from then, is that childhood stress and these types of events actually could lessen a person's lifespan by 20 years. So this toxic stress or these toxic experiences as children truly were leading to disease and becoming toxic in a person's body as we age. Next slide. And not surprisingly, we saw a huge direct correlation between ACE scores, substance use, and mental illness. And all of this is really important because if we look at a lot of these behaviors that may be isolated and not understanding this connection to trauma, usually the focus is addressing a lot of these behaviors and taking them away from a person, right? So obesity, we would want to say, we want to adjust a person's eating habits. With substance use and abuse, we might want to say we want a person to abstain from drug use. Not recognizing that what we're essentially saying is we want to take away the solution that you ended up establishing for this terrible trauma that you've experienced, right? So of course that's going to seem scary. Of course people are going to be resistant to that because that was their solution. And so this study has really turned the way that we look at things around, right? So again, rather than saying, what's wrong with you? What has happened to you? And rather than saying, this is, these are your problems, recognizing that they've actually been solutions to much bigger issues that person was experiencing. Next slide. I think in the interest of time, we'll skip Sarah's story, Kimmy, so we can skip this one and the next one. Next slide. So trauma in children is, this really basically supports the ACE study, right? So what we may see earlier in with children who are experiencing trauma is it comes out in different ways depending on the developmental stage. So when we look at infancy and toddlerhood, we're going to see things like disrupted attachment, cognitive delays, impaired emotional regulation, smaller brain sizes. We might see aggressive outbursts, right? A lot of, quote unquote, behavioral problems. And the reason for that is because, again, that brain rewiring, that impact that's happening is it's truly changing the person's brain regulation and how we are surviving this trauma. So, these are very, very profound understandings now that we're looking at trauma. Next slide. When we look at more school-aged children and adolescents, we're going to see something different, right? And so if you are someone who works with young people or in pediatrics, you may see some of these things, and even parents might be struggling with things that are behavioral or emotional, but not recognizing that, again, these might be reactions or responses to more toxic situations that are happening for that child. So we're seeing an impact on learning. We see an inability to form healthy social relationships, impulsivity. We might see increased number of sexual partners, right? Or quote unquote promiscuity, criminal activity. And then what happens? These kids get labeled as bad kids, problem kids, right? So again, if we're not thinking about what's happening, what has happened to you, what is happening, then we're going to miss really the root cause for some of these adaptations in a person's behavior. Next slide. And this is really important again. So the ACE connection of looking at the learning and behavioral problems that were reported. So for people who had for a 0 ACE score, only about 3% had learning and behavioral problems reported. If you look at 4+ ACEs, now we have 51%. And what happens is someone's going to come right into a healthcare provider maybe and say, like, why is this child acting this way, or why we need to find a solution to this. And if we don't address really the root cause of these things, we're not going to really see a change. Next slide. So in summary, what ACE studies tells us, and really what trauma tells us, is that it really does have this cumulative building block impact, right? So it's not just about one isolated instance, but it's about that ripple effect and all of the responses and systems that now almost have a domino effect when people are exposed to trauma. So we have ACEs at that bottom, and we see how these traumatic experiences can affect neurodevelopment. When our brains and our wiring is impacted, then we're going to be impacted socially with emotional regulation, learning, our ability to solve problems. We're going to even see this maybe in how we, can get along with others in school or at work. And then because of that, we see an adaptation of health risk behaviors. Yes, some of this is coping for immediate gratification, but we also know that this is really much deeper than that. And then because of those things, now we see the disease development and the prevalence of it, which eventually does lead to earlier death, right? But also what you can see is that there are many points where interventions can change this course for a person. There are many points in time where we might be able to, we might be the only person that ever asked the right question. And that most of the time people who have experienced trauma really don't put the connection together to what happened to them at one point and what's happening in their life later on, right? So people who might be alcoholic is not necessarily always going to put together, okay, alcoholism is a struggle, but don't really recognize, well, what happened to me when I was 8, 9, or 10 years old really put me on this course and it directly impacting it later, right? Thank you. Yeah.
Thanks so much. I was just thinking, this is just so relevant in every part of life. I have almost 12-year-old and a 9-year-old, and they, they're in school and they are always talking about, like, there's certain kids that are always a problem, right? They're always holding the class back. Everyone's getting in trouble and it's the same kids over and over again. And a lot of the parents are frustrated and trying to explain to my 9 and 11-year-old, there's a reason that child is acting that way. And like, that's obviously very complicated for a young child to understand. But even with the parents, that I'm trying to explain, that there's probably something going on there that they're not, that's not being addressed. And we need to have more empathy, which doesn't always work. Anyway, okay, so next slide, Kimmy. So we're going to get into how healthcare can help, which is really the focus of the next 5 webinars. I'm sure you have some ideas. So we're going to go through this pretty quickly, and we're going to talk a little bit also about, or quite a bit about, the small practice setting. So next slide. So really this is kind of what the literature shows and the movement shows, that there are really 4 main ways that healthcare can help. However, within each of these, there are many smaller steps and components. So our follow-up webinars will be addressing really how to do these things and what these things mean. So for today, we're just going to give a quick overview of them. All right, next slide. So I really love this quote, right? The body must be treated as a whole and not just a series of parts. I love it because it sums up both what we need to be striving for and also what we've done in healthcare, which is really the exact opposite, right? We've taken people and their bodies and completely compartmentalized them into organs and systems that run and function on their own. Trauma-informed care, which is person-centered by nature and by design, brings us back to this framework, which obviously holds that brains, bodies, systems, and experiences are all interconnected and all affect one another. Next slide. So many of you have seen this definition from SAMHSA, so I'm not going to, I'm not going to really spend much time on it. And we'll just go to the next slide for the framework, which can be referred to as these 4 R's, which is helpful in trying to remember. So trauma-informed care is care that realizes the prevalence of trauma and understands that recovery is possible. And Angela talked a lot about that, about understanding that recovery is possible and how common it is. It's care that recognizes the signs and symptoms of trauma in patients and staff. And this is really key that staff is included. We always talk about the fact that you cannot be trauma informed, and we try to talk to leaders about this for your patients, if you're not trauma informed for your staff as well, and potentially first, although it probably could be done around the same time. So it's care that responds by integrating knowledge of trauma into policies and practices. And the last one is something that I feel is really, really key, and something that at a minimum that we should be doing in healthcare is resisting the re-traumatization. Healthcare by nature can be re-traumatizing. So I feel like at a minimum, let's try not to re-traumatize people. Next slide. So because healthcare can be re-traumatizing, we often see its manifestation more than in other helping organizations or helping professions. And some is our fault, meaning that it's healthcare's fault. So I'm thinking, you know, there's so many current examples. Where do we begin and stop? But I'm thinking about the forced sterilizations that we heard about that happened at the border, right? So this is certainly going to leave a scar and an impression, and is traumatic. And how are those women and their families going to respond when they interact with the American healthcare system again, right? What are those behaviors that we're going to see, and then how are we going to deal with them? So next slide. So I said that healthcare is inherently re-traumatizing, unfortunately, and it is. So here's just a few examples of how. This lack of control or understanding of what's going to happen. So we go into the doctor, many of us not really knowing what's going to happen or what could happen or what, you know, they might tell us. So this is really hard for anyone, but obviously for trauma survivors, it's even harder. Our bodies are constantly being touched and examined, right? We're poked, we're prodded. Sometimes it's gentle and sensitive, but sometimes it's not at all. There are invasive procedures, exams, shots, right? We often have to have invasive procedures that really make the toughest of us feel vulnerable and deeply uncomfortable, right? Bright lights, very sterile environment. This is kind of self-explanatory. Closed doors, right? What happens behind those doors? We understand perhaps that it's for privacy, but it can feel different to different patients. Use of electronic medical records while talking to a patient, right? It can often be this like, where is this information going? What is it being used for? Or is this person even listening to me? Masks, right? So before COVID and especially now, we can't see people's faces. We don't know exactly, you know, we can't read them. There's a perceived lack or an actual lack of privacy, perhaps in waiting areas. Clinics and certainly hospitals can be confusing to find our way around, right? Sometimes we feel trapped. We don't know, you know, how to get out. Music choices, what's playing in the waiting rooms and in the exam rooms. Having to retell our story or never being able to tell our story, being cut off all the time. So these are just a few examples of how healthcare can be re-traumatizing. Next slide. So obviously we have to add this piece in around COVID because it's something that we've gone through as a group, but also depending on our COVID experience, you know, it can be perceived differently. So the masks, Angie and I spent a lot of time talking about the masks. They're necessary, we all agree they're necessary, but they really are scary, right? We can't see people's faces. We don't really know who is behind that mask. Is it really the nurse that I usually see? I can't recognize people that, you know, I can't recognize neighbors sometimes when I see them in their masks. Our temperatures, right, are taken without explanation. So we enter a healthcare setting and many other settings for that matter, and immediately someone aims a thermometer at us. It can feel like a gun or some sort of weapon. And there's this assumption that we all know what it is and why it's being used. I've been reading a lot that taking temperatures is basically useless. So do we really need it, or is there a better way to go about it? That's a different discussion. I get carried away. And it's in front of everyone, right? What if someone has a fever? It doesn't mean that they have COVID, but immediately that's going to set off alarms. We're going to be judged, perhaps embarrassed in front of everyone. And then what? We don't get the care that we might need at that moment. So we're often allowing only the patient now to come in. What does this mean for people who are disabled? What does this mean for people who really need a support person there for anxiety, for fear, right? Sorry, guess not anymore. So next slide. So here are really the ingredients of trauma-informed practices. Communication, right? Sharing this information widely, discussing it at meetings, making it part of how we operate. This is a great first step. Engaging patients, if possible, in planning to be trauma-informed. They can offer amazing and insightful feedback about our services and how they experience them. We should ask them, we should use them. Many of them, some of them may not want to, but many of them might, and they might be flattered. Training all staff, right? This is key. Everyone needs this information, from the security person, and definitely the security person, if there is one, all the way to the physicians. This is not information for only clinical staff. Creating a safe environment for staff and patients. We'll discuss again what this could look like. Preventing secondary traumatic stress in staff, another really important ingredient that we'll cover on another webinar. We must support our staff, many of whom had their own trauma or at least been involved in group traumas, and more so now than ever, right? We have all been through so much as a healthcare community. Let's see here. Building a trauma-informed workforce. This does not mean rehiring everyone, of course not. It means training and asking about how people will approach different situations in the interviewing and onboarding process, okay? Just gonna try to, all right, next slide. Okay, being person-centered. So the thing that's great is that trauma-informed care is by nature person-centered. And I always like to joke that these things like person-centered, trauma-informed, culturally responsive care, these are really all the same things. When we really look at them and what their core is, they are very similar. So if you're trauma-informed, you're gonna be person-centered, and you can kind of check that off. We have to screen, obviously. We'll have a whole webinar devoted to that, particularly around how small practices can get it done. We have to train staff in trauma-specific treatment approaches, right? We also have to, we don't have to necessarily be trauma therapists, but we certainly have to be able to refer out to places that do good work around trauma. And that really leads into these engaging our referral sources. We don't have to be everything, but if we don't know how to respond, we cannot screen. And I would say in all of the work that I've ever done around screening for things like intimate partner violence and depression and now trauma, the #1 reason that people say that they don't want to screen is that they don't know what to do when a screen is positive. So that is a real concern, and we're gonna tackle that. Okay, so let's go back, next slide. We're going back to Isabel. Everyone remembers her, right? She's pregnant, has diabetes, high blood pressure. She hasn't been keeping up with her appointments, right? And we all said how we felt about her. So let's go to the next slide. So what we don't know about Isabel is that she has a history of sexual violence with multiple victimizations. So this pregnancy has been extremely triggering, igniting panic and dread about her impending labor and delivery. She doesn't know how she's going to handle it. So now how do we view the patient? And then I want to ask you, and use the chat box, what is it about labor and delivery that is triggering her? And then what can you do? And you can answer any of those or all of them. We don't necessarily need to be in the right order. Any thoughts? Lack of control. It happens when it happens, very personally invasive, absolutely. Yeah, so obviously we can't know exactly without asking her. It hurts, it's vaginal, yep. But we do know what labor and delivery involves, and we know that it involves a lot of loss of control, prodding, right, by many different people. So this is what potentially is bringing her back to her sexual assaults, where she was harmed and had no control over what happened to her, right? Perhaps pregnancy is reminding her of her sexual trauma, someone wrote, absolutely. Okay, so what can we do? Any thoughts? I would want to, here someone wrote, I would want to make sure she can identify a support network where she can think about people in her life who would be a positive influence and assistance in this time. Excellent, right? What does she need? Is there someone who can see her through it? I always think of, and if someone has no one, I would think of like a doula. And I know many insurances are now paying for doulas as well. Any other thoughts? So yeah, just things about, I mean, obviously we know we can plan and have the best birth plan ever, and that can happen or not happen. But really trying to think about things that might make her feel better. Maybe only having a female, provider would make her feel much, much better. Maybe she needs a certain type of music, right? So there are things that we can do. Someone wrote, recognize that pregnancy is difficult and ask how she is coping with the stressors of pregnancy. Awesome. Mm-hmm. Okay, next two slides. So I think if we have time at the end, I know we're almost out of time, we'll come back to John, but I think you're getting this. So let's go to the next slide. Yep, case study summary. So we really covered this, right? That problem behaviors may actually be manifestations or symptoms of trauma, right? So I think we actually really went through all of this. So let's go to the next slide. I really love this slide because it contrasts how someone who has not experienced trauma may view their world versus someone who has experienced trauma may view their world, right? So I live in a predictable world. The world is unpredictable. I am worthwhile. People want to hurt me. I'm hopeful and optimistic about my future in life. I'm not safe, and no one will help me. I have the ability to impact and change my life for the better. I'm not good, smart, worthy enough for people to care about. I trust myself to make decisions versus it will never get better. I can't even trust myself. Someone wrote in about colonoscopies. Yes. And even, right, we're asleep during colonoscopies, but that can raise a whole new thing, right? What's happening to me when I'm asleep? Not all of us feel like my father-in-law who looks forward to his because he says it's the best sleep he gets every, several years, but that's not the common feeling. Okay, next slide. So why small practices? Let's go to the next slide. So small practices are actually perfectly positioned to address trauma. They've been in practice sometimes for a long time, and they're often really trusted in the neighborhoods. They have uniquely strong relationships with both patients, the families, and even some other, like businesses and community groups. This is in comparison to larger practices. So this is actually a perfect foundation for implementing trauma-informed care. In fact, I would say there is no better foundation for implementing trauma-informed care. There's often less bureaucracy, so it might be easier to begin new programs and screenings. This could be up for discussion, but I know I have worked in both very large hospital systems and smaller healthcare centers. And when you're trying to do something new in these big systems, it takes forever, or at least it seems like it takes forever. You don't necessarily have those limitations in smaller practices. Many are located in high poverty areas, right? And these are certainly populations that will be affected by trauma, both because of historical issues, right? Poverty, racism. So the trauma-informed care is always going to be relevant. And oftentimes, the providers and staff reflect the ethnic and linguistic makeup of the communities they serve. So this adds to them being trusted by patients. And we know from research that small practices actually provide high quality care, a greater level of personalization and responsiveness to patient needs with lower average cost per patient and fewer hospitalizations compared to larger practices. So this is what we know. So they're really perfect. Next slide. However, they may be perfectly positioned to do this work. However, there are challenges that require different kinds of strategies than for bigger health systems. And we have a whole team at Primary Care Development Corporation, a small but mighty team, who do work primarily around small practices. So we have a lot of expertise in this area. They may have limited resources, including number of employees, a limited amount of money they can spend on implementing, new screenings, new programming. So sometimes they may be the last to implement the latest technology and screenings due to overhead burden. But there are opportunities. So, and they often do require a different workflow, perhaps a different staffing model than, let's say, a larger health system. And for people who are filling multiple roles, they may actually be excited to learn something new or take on a different role. Next slide. So we already talked about this, that they need support that's tailored to their business model and model of care. So obviously there's a huge opportunity here in California that California will now pay your practice to screen for trauma. This is amazing. We will work with you to take full advantage of it, but also make it doable and hopefully not overwhelming. Webinars 2 through 4 will really go through this in detail. And there's a huge opportunity to improve health and well-being of both families and communities by really addressing the root causes of illness. Also a great opportunity to rethink the roles of support staff and work in a more team-based approach. And we know that when healthcare organizations take on team-based care, they have better staff and provider satisfaction. So small practices by nature may feel less triggering to trauma survivors just because they're smaller. They may have fewer people coming in and out and maybe physically a little bit like nicer or more approachable. This isn't probably true across the board, but it's definitely a possibility. So next slide. So these are some of the topics we're going to talk about in the follow-up webinars, right? What does a trauma-informed workforce look like? What does a trauma-informed physical space look like? Reception, they set the tone. What's a trauma-informed clinical encounter? How do we screen and respond in the right way? How do we give control back? And how do we give patients choices and really listen to them? So the last slide, next slide, please. I just want to review very quickly again. Our second webinar is setting the stage for screening and trauma-informed practices. We're going to talk a lot about the physical environment and the front desk. The third webinar is about the clinical encounter, exams, tests, procedures, right? What can people doing clinical encounters actually physically do to become more trauma-informed? Things literally from like standing in one place versus a different place can make a big difference. Webinar 4 is all on screening and responding. And webinar 5 is about staff wellness, vicarious trauma and burnout. Is it real? What are the differences? And then the 6th webinar, we're really going to take from the participants, really what people want to, what topics have been coming up as we've been going along that, people are interested in. So probably we won't get a ton of you staying after for this webinar, but the idea is that in the follow-up, and please feel free to stay if you want to after this webinar, after we're done with the formal portion, to ask more questions and take yourselves off mute. But the idea is that, we will have people who, we have Angela, who's a trauma expert, me, who's implementing, lots of programs in different types of places. We have our colleague Anuja, who's a small practice expert. So the idea is that you could really talk one-on-one with us about, what you're going through and particular challenges that you're facing, or things that have been working really well that maybe, we should share out with the rest of the group. So that's really the way these are intended to go. And we will send out, Kimmy, I think we can send out again, we can send the registration information again, because unfortunately with the system, you have to register for each one separately. Sorry about that.
Yeah, for everybody that's on the call today, I'm going to follow up with you with a copy of the slides that we covered, and I will include the flyer that has links to all of the other sessions, and you can register that way.
Perfect. Thanks, Kimmy. So next slide is really about what questions you have, and we'd also love to hear about what you need, what you think you need to begin this journey or continue the journey if some of you have already been on it. I know we had someone wrote in, for me, knowing that trauma doesn't discriminate, I would have preferred that we highlighted the location be needed in all areas regardless, not just necessarily or just high poverty stricken areas. Absolutely. I think just because of the ACEs aware work being targeted to providers that are accepting Medi-Cal, that's just kind of where we end up. But we certainly heard from Angie, and we all know from our own research that the trauma doesn't seem to discriminate. But certainly in areas where there's collective ongoing chronic trauma like poverty, like racism, it's going to be especially just as relevant there. But thank you for that. Anyone else want to chat in a question or anything? All right, well, we're going to hang out for a few minutes. So I know we're a few minutes late, sorry. If you have something to do, please get back, enjoy your afternoon. But we'll also be on if anyone wants to stay on. And Kimmy, I think we can take people off mute, or people can unmute themselves if they stay on.
Yeah, if people stay on, I will give them the ability to unmute themselves.
Great, thank you. So I just want to, for those of you who are staying on, someone wrote in the Q&A, in some states in the United States and territories, a movement that promotes hatred towards men and people who think differently from feminism is growing very fast. This can be a huge public health problem due to the increase in violence and fear. We definitely understand that violence between genders, ethnicity, religion, etc., must end in all ways. How can trauma-based care be a model of best practice to ensure equality in health and social services, including incorporating a gender perspective? Wow, I got to think about that for a minute. Any thoughts, Angie?
Yeah, I mean, I think one important aspect in all of this is that we're speaking in generalized terms, but what it really comes down to is that every person's experience is very individual and unique, right? And so incorporating trauma-informed care really assumes that type of practice, right? So that incorporating a gender perspective is going to be an aspect of that trauma-informed care, and really will be working with the individual and what their independent experiences have been, right? And I'm thinking in this example too that, thinking about working with gender non-conforming patients and, people who don't fit in this, very, the very gender-based male-female dynamic as well. And so, so really, how can trauma-based care be a model of best practice? That's what this whole entire series is going to be about. So hopefully you will come back so that we can have these, really engaging discussions about how do we take this and tailor it to meet the needs of people individually.
Yeah. Anyone want to add anything? Anyone else who has thoughts about this?
There's another really good point that was just brought up in the chat. When my patients bring up social and political concerns, it feels awkward sometimes not to get into it, but I will try to focus on what that means for them and how it impacts them. And I think that that's so important. And thank you so much for sharing that, especially now, because I think we probably are all struggling with that a little bit as far as where those boundaries are and, you know, what do you say and how do you support someone individually? You know, whether you share the same political views or values, or if you are absolutely opposing, right? And that is definitely a struggle, and, you know, really is why all of this is so much more, you know, challenging to implement than, you know, the nice kind of like quick slides that we put up there, right? That's why we're here. If it was easy, then there wouldn't be a need for any of these webinars. So you're not alone.
And someone asked, is it appropriate to ask how to engage leaders of large organizations who don't understand or see the economics of screening for ACEs? Yeah, I mean, it's completely appropriate and completely necessary. We're going to focus on small practices, but certainly, you know, when we do this work in a broader sense, we always try to get to leadership, whether it's trauma-informed care, person-centered care, team-based care, and like whatever, any type of program or shift in thinking that you want to do, we're always trying to get to leadership, because it's really hard to do anything, you know, in a very, very thorough way without, you know, leadership, at least supporting, you know, supporting it. And, you know, this, and certainly the economics can be challenging because they may not, like, for if you think about small practices, they may not see, aside from the screening money, right? But if they're really doing great trauma-informed care, they may actually see patients less. Dare I actually say that? And so in a fee-for-service model that most of us are still in, you know, we may not see those economic benefits. That might be something that the hospital sees more of, or whatever. So yeah, it's can definitely be challenging. Does anyone else want to say anything about that? Anuja, do you want to come off mute and pitch in?
I actually just wrote to you guys. So pitching it to a larger organization, they're unfortunately always thinking about dollar signs. And so with this screening in general, there is a billable code once you go through the 2-hour training through the state of California. So that's kind of another way that you can pitch it to them, which, you know, ultimately means that you can make a little bit of extra revenue if you to bill for the screening.
Yeah, it's great. Because I mean, a lot of what we do doesn't have a billable code necessarily. So this is so exciting because you can, you know, you really can you will get paid for it. All right, well, we're going to hang out a few minutes longer, but if you need to get on with your day, feel free. It's been a pleasure being with all of you.
Yeah. Thank you so much. We look forward to seeing you at the next session.